Good afternoon. It's my pleasure to introduce Dr. Gelineau-Morel, a pediatric neurology specialist at Children's Mercy Hospital and an assistant professor of pediatrics at the University of Missouri, Kansas City. Dr. Gelineau-Morel's research focuses on precision therapeutics for children with acquired dystonia and cerebral palsy. Please join me in welcoming Dr. Gelineau-Morel.
All right, thank you so much. I'm excited to talk to everybody today, so thank you for inviting me. So I included a picture of a road here because this is going to be a little bit of a turn from our previous talk, where I work in the intersection of clinical pediatric neurology, taking care of my own patients with movement disorders and cerebral palsy, and then with the clinical pharmacology world and precision therapeutics. So I wanted to take you on a bit of a trip of how I began to work in this area and how my patients inspired me. Just a disclosure, I will be talking about today some of the work that led to our patent and is currently being developed as in clinical trials. So what I'm going to be focusing on today is trying to improve treatment for dystonia, which is a movement disorder that is quite common, and many children and adults with cerebral palsy or genetic conditions can suffer from. So I think, I included this as the technical definition, but I think that sometimes a demonstration is a little easier to understand what dystonia even is. So let's say we have this water bottle here. So if I were to reach out to try to grab this water bottle, I do this automatically. The correct muscles contract and relax. My cortex fires off and goes into the deep gray matter structures in my brain, triggers certain motor programs, and this all happens without me even really thinking about it. But in someone who has dystonia, be that either from a brain injury or from a genetic cause, their cortex can send the same signal, I want to grab that water bottle. But then somewhere along the way in that network of connections in the brain, they get scrambled, and instead the wrong muscles contract and relax. Perhaps other muscles start to move and they're trying to reach to grab this water bottle, but instead they end up completely contorted. And this can be painful. Of course, it severely impacts your function, and it can even land people in the hospital, in the ICU, in status dystonicus, with muscle breakdown and multi-organ failure. So this is really something that we need to treat. It's actually pretty common for us to see it in kids. So acquired dystonia, meaning dystonia that was acquired from a brain injury. In cerebral palsy, that's the most common cause of dystonia in childhood. And it's about a similar incidence to Parkinson's disease if you think about it in terms of overall population of children in the world. But despite this being a really severe problem, we have significant delays in the diagnosis of dystonia. People are not very great at recognizing it. And then furthermore, even when we do recognize it, we don't have great treatments. People differ very much in their response to medications. And when I am treating my own patients, I say, well, we could try this, we could try that. I don't know which one's going to help. We'll start at a low dose and gradually go up, and at some point you'll encounter side effects, and then we'll move on to the next medication. And that's pretty much what we have as our options. So we really need to provide better treatments for people, especially because we also have evidence that shows that earlier treatment of dystonia in young childhood results in more effective therapeutic outcomes compared to people who are treated as adults. So what do we have in terms of our treatment options right now? Well, I'm including here, you don't need to read all of this, but this is a snapshot from a recent review of pharmacologic treatment options for dystonia. And what you really notice is a lot of things, the level of evidence is extremely low. It's basically anecdotal evidence. And there is, many of they say little to no difference or may improve the dystonia. So we have a lot of options of old medications that are not very effective and don't have very much evidence. And in fact, we don't have any FDA-approved oral medications for the treatment of dystonia in children. So how can we use precision medicine to address these knowledge gaps and try to improve the treatment of dystonia for children and adults? So this is kind of what was the foundation of my own research, and I've really tackled it in terms of 4 different steps. So first of all, as I mentioned, this is a disorder of networks in the brain, how different parts of the brain communicate with each other. So are there predictive markers that we can use to say this person is likely to develop dystonia so we can implement an earlier intervention? Once we get to that point, is there a targeted intervention that we could use? Perhaps based on which networks are perturbed in your brain, you would respond better to one intervention than another. And then once you've identified the intervention, can we identify more individualized dosing recommendations so that we don't just use that start low and go slow philosophy? And then finally, can we then measure response in a quantifiable and accurate way across people? So, I won't have time to talk about all these different areas today, so I'm just going to be focusing more on how I started looking at what would be a targeted intervention that we could use that we think would be more effective, and how we could dose this more accurately and effectively for each person. So thinking about targeted interventions, I started looking into what information or what data do we have to help us decide what type of an intervention would be best and people would respond to best. As I mentioned before, we know that dystonia responds better to early intervention. This is based on a lot of response that people have to deep brain stimulation when you have an actual implanted stimulator and people respond to dystonia. We find that earlier implantation of the deep brain stimulator results in better outcomes compared to later. And so we generally are wanting to provide early therapies to treat dystonia in at-risk patients. Well, what is the pathophysiology, we think, of acquired dystonia? So what's causing this abnormal connections and network that's causing this movement disorder for people? Well, some data that we have developed here in our rodent models has demonstrated that actually with chronic excitation of the striatal cholinergic interneurons, so specific class of cholinergic interneurons in the striatum, so some of the deep gray matter structures in the brain, if those are chronically stimulated, then that leads to the development of dystonia. This is really interesting because we did not find that same relationship with a short period of stimulation. So you could equate that to the beginning of the injury. You lose the inhibition on those cholinergic interneurons. They begin overfiring. You don't develop dystonia right away. You have a period, a window of opportunity, I would say, which you could intervene early before you begin to develop dystonia. So if we think that dystonia is due to chronic misfiring of these cholinergic interneurons, providing too much cholinergic activity, it would make sense that we could treat it with an anticholinergic medication. And this is not a novel concept. There are lots of anticholinergic medications, or a couple at least, that have been developed and used for treating dystonia and related disorders such as Parkinson's disease for a long time. One of them is, an example, the medication is Trihexyphenidyl. This is an anticholinergic medication. It was approved in 1949 for treating Parkinson's disease in adults and also is used for treating other extrapyramidal movement disorders. And now it's one of the most common medications that we use for treating pediatric dystonia as well, of course, off-label. And we find that it can be remarkably effective for some patients. There are actually, very videos that kind of circle through the pediatric neurology community of people on high doses of trihexyphenidyl that go from being unable to walk to being able to walk again. I mean, it can be quite effective. But others can't take it due to severe side effects, anticholinergic side effects, and then just lack of efficacy. For some people, it just doesn't seem to work. We don't really know why. So what is it about trihexyphenidyl that we could explore a little bit further to see, could this actually be more effective for our patients? And when you look into the specific mechanism for trihexyphenidyl, not only is it an anticholinergic medication, but specifically its action at the M4 muscarinic receptors that are highly present in the striatum, that is what is associated with normalizing dopamine release and improving dystonia. So we look at this kind of balance of dopamine and acetylcholine in the brain. And it seems like trihexyphenidyl, specifically by acting at those M4 receptors, is helping to fix that balance. And there actually was a clinical trial, a small clinical trial of 31 children that was performed on trihexyphenidyl in children with acquired dystonia to see if that could improve their dystonia. Now, you see immediately of those 31 children, 3 had to withdraw due to adverse drug reactions, and then 3 required a dose reduction. So it was, it's something that, as we mentioned, is not always very well tolerated. But they did notice that after a long enough period of time, 15 weeks in this case, that they had significant improvement in their arm function and their motor dexterity. But with a small subset having where it almost worked too well. They had extra movement, hyperkinetic movement, instead of too little movement. So with all of this, there's the current recommendations, and this is from the Cochrane review, but saying that there's insufficient evidence regarding the effectiveness of trihexyphenidyl for people with cerebral palsy, citing these concerns of variable effectiveness and excessive side effects. So what can we use from the clinical pharmacology world to look into this and say, why do we have such a variable response within people? Why is it that some people respond so much better than others? Why is it that some people have so many more adverse effects than others? Is there something about the dose exposure response relationship that we can look at and untangle to understand this better? So then we started looking at, well, what do we know about trihexyphenidyl and how it's metabolized? Is there a difference in the way it's metabolized between different people that could impact this variability? Sort of like we had the question that we had for the previous talk. Well, so here's a picture of the molecular structure of trihexyphenidyl. And actually, when I was first looking this up, now it's probably 5 years ago, but there was very little known about the metabolism. Actually, this is one of the resources I looked at where the metabolic fate has not been determined. It's excreted in the urine, probably as unchanged drug. Well, I mean, this was developed in the 1940s. They didn't really have very high bars for approving medications at that point. So I think that we didn't know as much as we should have. So we ended up running a screen based on the metabolic structure. We felt that it was likely CYP metabolized, and we did a screen of CYPs and did find some metabolite in about 5 key CYPs, but especially we noted more in CYP2D6 and CYP2C19. But the picture was a little bit more complicated than that, because trihexyphenidyl is actually given as a racemic mixture. It's a 50-50 mixture of the R and S enantiomers. And so then we started wondering, well, what's the difference there? And could there be stereoselective metabolism? And then also in terms of its effects in the brain. And back in the 1990s, when people were looking more into trihexyphenidyl, it turns out they actually had found that the R enantiomer has a much greater binding affinity than the S enantiomer, specifically for the M1 and those M4 receptors in the brain that we are wanting to target. The S enantiomer has more equal affinities for all of the receptor subtypes and is not so, it doesn't have such stereoselective targeting like the R enantiomer does. So then we did the same thing, breaking down the CYPs, and here I've shown more specifically for the CYP2D6 and CYP2C19 as well as CYP3A4, which were the ones that were most predominant for metabolite formation. And we saw here in the middle is the racemic mixture of trihexyphenidyl, but you see quite dramatic differences when you break it out between the R trihexyphenidyl and the S trihexyphenidyl, showing there is very stereoselective metabolism. And as I think that you are all aware, this is pretty important because we know that that CYP2D6 and CYP2C19 that seem the most involved in the R and S trihexyphenidyl metabolism are highly polymorphic. There are many variants that you can have of each of these that can lead to multiple phenotypes ranging from no function to ultra rapid metabolism with those enzymes. And so you think about, we're giving something to people that has a combination of these two enantiomers. Each one are metabolized by different CYPs that are both polymorphic. So you could end up with higher or lower levels depending on what your genotype and phenotype is. Not to even mention that these children and adults are very medically complex, on multiple other medications, have a lot of other factors that could also be impacting their exposure to these enantiomers. So we felt like at least this was something worth looking into as a potential cause of variability. And that led us to our current study, which we're calling the TRIKE study for trihexyphenidyl kinetics. Also has a bit of that movement portion in there. And so in this study, we are looking at children. I am doing this all in children. And actually, we start off with genotyping them for their CYP2C19 and CYP2D6 genotype. So this is a genotype stratified study just to try to make sure that we get representative people from each of these poor to ultra rapid metabolizers. And then we enroll them in a first dose PK study, a traditional PK study, and look at their levels of R and S enantiomer that they're exposed to, and then follow them over 16 weeks, similar to that study that we discussed previously, and look at markers of response in terms of how does their dystonia respond, as well as adverse effects that they may be experiencing. And we collect remote sampling using the TASO device at times if they have extreme response, be that either an extreme good response or an adverse effect, to see if we can identify what exposure they have to the enantiomers at that time. And the idea is for all of this to then be able to to inform drug labeling, hopefully for children, and to provide more precise dosing. And as a benefit from this, as I mentioned at the beginning, when we were discovering all this, we filed a patent for the isolated R trihexyphenidyl for treating movement disorders, thinking that that's the enantiomer that targets the receptors that we care about or that we think are more important. And if we just isolate the R trihexyphenidyl, get rid of the S trihexyphenidyl entirely, we could target the receptors we care about more and avoid some of those problems from having two different enantiomers with stereoselective metabolism. And that has been picked up by a drug company, and so it's actually currently going through clinical trials in adults as well. So we'll see how that pans out. So in our children, what we've seen first, and this is based on our first dose PK study, and this is just, I pulled out a few parameters here that I thought were interesting, but you can see already looking at our max, our Cmax and our AUC, the huge variability that we are seeing. This is an example of some of the difference in our initial concentration that we got. So our Cmax right here was in one, on the left was over 80 nanograms per ml, and on the right about 15 after one dose. And then here looking at kind of some differences in the R and the S ratio between the R and the S enantiomer. And you see here as well that we have one person that they have absorbed and we're seeing the pretty much all R enantiomer, whereas this other person has about a 50-50 ratio of R and S that they are being exposed to. So how much could these differences be impacting their response? And this is currently ongoing, so I can't tell you yet. That is what we are trying to understand better right now, is how much of this is due to their genotype, so the CYP2D6 and CYP2C19 that I was alluding to earlier, versus how much is due to the types of feeds they're getting, the medications they're on, et cetera, et cetera. This is a population of children they're very medically complex, which creates quite a few barriers in terms of understanding, but also in terms of enrolling them in these studies. So we are also taking advantage of that and collecting sparse samples from clinical stays, where we can opportunistically collect from clinical blood draws more samples to add to our data. And then that touches on something else that's related and that has become another real passion of mine when doing this work, is in promoting research inclusivity. This is a whole population. As I said, there are no FDA-approved medications for them. This is a population of children and later adults who are frequently hospitalized, are in and out of the medical system all the time, and yet they're excluded from pretty much every clinical trial and not eligible to participate. I did a survey of patients in our institution that have a child in their family with cerebral palsy, and 85% of them reported interest in participating in research, but only 47% had even been approached in the past to talk about it. So there was a big gap there. But when you look at kind of how often they're interacting with the medical system, about half had 10 outpatient visits or more in the hospital in the year. A quarter of them live 2 hours from a research hospital. So, that's a significant barrier to participating, but I'm also from Kansas City, and so we have a lot of people that are coming in from outside of the city. And then 86% of these families had more than one child in the home. So another thing to think about when you're doing research in children is not only the impact on the child and their parents, of course, but their other siblings, and how can we accommodate them. So we also asked and have found that, in order to address these barriers, what could be some things that we could do to design studies to be more inclusive so that the people who want to participate in research actually can. The biggest barrier was time. There are already, as we said, 10 plus visits a year, often an inpatient stay or more every year. People repeatedly described combining research and clinical visits as something that they were interested in doing to help allow them to be able to participate in research. So we've done that. We try to do we have a steady state PK study that we also do, that we will do during their hospital admissions. And so that is some way that we can work that out. And we try to coordinate our first dose PK study with when they're already coming to the hospital. People prefer virtual visits, unsurprisingly. We have a hard time doing virtual PK studies, but as I mentioned, we do use the TASO device, and so we use that to try to help people not have to travel in as much. They'll actually do their sample collection at home and mail it in to us, and that has worked really well. And then we have provided a space and child life support and things for siblings so that they can attend the studies as well. So these are just things that I didn't necessarily imagine that I would be thinking about or getting as much involved in when I started doing this work, but is really important if we're going to improve the research and that we have for these children. So this is a picture of some of my team, and thank you all very much.
Hi, Rob Bees, University of Buffalo. Very interesting studies. I was curious about the use of the TASO device. So when you use what is your experience, or do you have experience in terms of how that's enhanced the ability for individuals to, or for your patient population to participate? Is part one. And part two is when you get the samples, are you able to get measurements that are equivalent to a plasma concentration, or is it closer to something like a dried blood spot?
Yeah, no, we actually are able to get a plasma concentration. We had to check first the stability of the trihexyphenidyl, so we actually just took a sample and left it out for 7 days to see what would happen in terms of the concentration, and it was quite stable. So then we were fortunate in that regard. And we have had people use it more and more. At first, we began by just starting to use it for steady state sample collection. So we were having them collect it several weeks into the trial to just see what it was at steady state. And then they came back in at the 16-week end mark, and we took another sample there just to see, make sure that it was stable. So we used it that way, and then that was so successful that we started actually using it to shorten our PK study. So because we have a lot of people, well, first, we're dealing with bedtimes and things that, the children have. And so they want to get home for bedtime for their child and the other kids in their family. And so we do an 8-hour in-house, PK study. And then we do a 12 and 24-hour draw as well. And those are done at home. And then they ship them back to us. And so that's worked out well. We give them the option to come back in, but we haven't had anybody take us up on it yet, because once they try it, we also demo the Tasso device on them at the 8-hour draw so they can see what it's like, so the parents feel comfortable with doing it. And once they've seen that, they're like, no, I'm good, I'm just gonna do this. And and it works out really well. It truly is pretty much painless. I don't know if anybody's tried them or how many of you have, but it feels just sort of like somebody kind of swiping your finger across your arm. It's more pressure than a feeling of pain.
Thank you.
Yeah.
Hi, Ryan Jarrett coming from Eli Lilly. So one very simple and practical way of handling all the variability in the PK that you see would be to do some sort of therapeutic drug monitoring, where you adjust the dose in response to what you see for this patient. Is this being done in practice, or what are the barriers to doing this?
Well, part of it is that we don't know we don't have an estimated, concentration or that we are looking for, in terms of the
Or what was
plasma levels.
therapeutically
Yeah.
relevant.
Right. And so we don't know, that's part of this, is to figure out, okay, of the people who are responders, what plasma levels are we seeing? And does that differ from those who are non-responders? And does that give us a target level to shoot for? Because ultimately, yes, I think that would be the goal. And that's kind of another goal of this, is for a future, larger clinical trial. Can we use this to inform dosing, and then also inform kind of what our target concentration should be?
Okay. Thank you for a very good talk.
Tom Callahan again at IU. I wondered, would I be misinformed to assume that there are a fair number of these individuals on a lot of other CNS medications? And if so, a lot of them, of course, are involved in blocking, inhibiting, rarely inducing 2C19. But the question is, are you eliminating those people from your trial, or how are you handling phenoconversion possibilities?
Yeah, so we are including everybody, but obviously taking very clear measures of not only what other medications they're on, but what dose they are receiving, when they receive that dose, so that we can see the impacts of that. We have a lot of kids that are on PPIs that are, for their gastric problems that could be impacting their CYP2C19 phenotype. And, I think that basically, it looks like they're likely basically phenoconverting to the phenotype that's the lower phenotype, basically. And so they are, so we're just keeping that in mind, and we'll have to take that into account with the final model.
Thank you.
Yeah.